Good morning, CHI. Each quarter, we hold a general care team meeting. And of course, this is an opportunity to share current information about CHI and to hear from you with your concerns. Before we get started with our PowerPoint presentation, I just want to tell you we had a grand event on Saturday, the third graduation ceremony for our physicians who are graduating from the residency program, and it was awesome. Anybody agree with me? And I am not going to try to call all the names of people involved, but everyone who was involved with the graduation ceremony, the planning, the presentation, the food preparation, the table decor, the grandstand we had up there. Everybody just stand up who was involved with that activity. Please, just stand up and be recognized. Everyone. Yes, they deserve a hand, so thank you so much. I wanted to do this because it's a little different from what I usually do, but it was such an awesome event that I expect that all of you should be recognized on this occasion. So let us begin to talk about Community Health of South Florida, CHI. Let's talk first of all about the governance, the board of directors of CHI. You need to know who the board of directors are because they are the ones who control our activities and determine what services we are to provide and the locations from which we will provide that service. And you will note from this slide we have the chairman, Mr. Arjun Saluja, an astute businessman in our community. We have the first vice chair, Jeffrey Coldren. He is a contractor in the Florida Keys. Mr. Louis Torrens, who previously served as the chair himself and is now the second vice chair. Mr. Carlo St. Cyr, who is the treasurer, and Maria Garza, who is the secretary. I won't go through all the other names, but I wanted to be sure that we recognize the officers. So what is CHI's motto? Oh, come on, you can do better than that. What is CHI's motto? Patient care comes first. And we repeat this over and over again for those of you who may be new, because that motto drives everything that we do at CHI. If you're on the phone and the patient needs care, you take care of the patient. Patient care comes first, and that's the driver of our activities at CHI. We are on a journey to excellence. Perfection is not attainable, but if we chase perfection, we can catch excellence. We are on a journey to excellence. Our mission is to deliver safe, accessible, compassionate, and culturally competent quality healthcare services to the people of South Florida while training the next generation of healthcare professionals. We continue our journey to excellence, and our vision is to become the health care provider of choice for the people in South Florida and a teaching center of excellence for healthcare professionals. We're well on our way. The third graduation of physicians from our residence program. Our values: I care. The I is for integrity. I am passionate about being honest, sincere, and presenting myself with the highest moral principles. C, compassion. I will strive to show concern and kindness to others, especially while caring for our patients. A, accountability. I am responsible for my actions and will deliver on all commitments within my control. R is for respect. I will always be respectful of others and strive to be mindful of different opinions, cultures, and beliefs. And E is for employees. I am part of a patient-centered healthcare team, and our employees are our greatest asset. Together, we deliver excellent service to our customers. This journey of excellence started with the Studer Group. And we are the first and only FQHC to receive the Governor Sterling Award. With Studer and with Sterling, we have provided training in Six Sigma for nearly 70 staff members, including Yellow Belt and Green Belt. CHI is a great place for patients to receive care, a great place for providers to practice, and a great place for employees to work. This is our journey to excellence, and we will continue this journey of excellence. Our focus for 2019 is in two areas: productivity and wait time. And while we have talked about this with the staff, the senior staff, we need to emphasize it at this occasion to everybody under the sound of my voice. That is the only way we're going to make progress in these two areas. We must increase our productivity to the expected level. And when we talk about productivity, we're not talking about just the provider. We're talking about the whole team being aware of and actively engaged in the promotion of productivity within our organization. We must see the expected number of patients every day. One of the greatest complaints from our patients is the wait time. And so that's the reason for focusing on that particular aspect of our operations. And again, it is not just the provider who is concerned with wait time. The entire care team is concerned with wait time. And we all must do whatever we can to reduce this really area of complaint from our patients. The 2019 theme, AAACT, alignment, action, accountability, compliance, not tomorrow, but today. When we look at the history of our organization, from humble beginnings in 2 trailers in 1971 near U.S. Highway 1 and 216th Street, CHI began with a commitment to community-oriented primary care for all residents of South Miami-Dade. That same commitment is evident today. And today, CHI is one of the largest of over 1,400 such healthcare systems in the United States, providing comprehensive integrated primary, behavioral, and HIV/AIDS services to our community. We now have 11 healthcare centers, 35 school-based centers, and we are always in a growth mode. Some economic information about the impact of CHI provided by the Florida Association of Community Health Centers. CHI injected $64.8 million of operating expenditures and induced an economic activity of $60 million. Therefore, it had an overall economic impact of $124 million. We supported an additional 430 jobs in other industries and employed over 700 staff members with a payroll, including fringes, of over $42 million. CHI pays a lot of rent, a lot of mortgages, and a lot of cars, as you can tell by our parking lot. So if we talk about CHI, let's talk about Florida. Florida FQHCs provide primary care services to 1.5 million patients at over 500 locations across Florida, including mobile, dental, and vision units. The economic impact of Florida's FQHCs in 2018 was $2.1 billion. Florida's FQHCs provide a return on investment of 177% for every dollar contributed. And Florida's FQHCs act as a valuable employer, accounting for over 18,700 jobs in 2018 in local communities across the state of Florida. That's not small potatoes, folks. The FQHCs are a great contributor to the economy of the state of Florida. Let's talk about a few of the achievements of CHI. We have received the HRSA Health Center Quality Leader Award for 2018. We are accredited and reaccredited by the Joint Commission in Ambulatory Care, Behavioral Health, and we have achieved the Patient-Centered Medical Home Level 3 by the NCQA, and we are the second FQHC in the nation to become a behavioral health medical home. Chamber South 2019 winner of the Multicultural Workforce, recognizing the diversity of our workforce by the Chamber. And the Greater Miami Chamber 2019 finalists for the Healthcare Hero Award. We won this in 2004, but we were against some very stiff competition this time, so we ended up as a finalist. Other achievements. We have achieved meaningful use with the electronic health record. We've been recognized with the Studer Group. We received the Chamber South High Growth Award. 2016, recipient of the Governor Sterling Award. We are one of 50 FQHCs invited to participate in National Network for Oral Health Access. The only, I say this with great pride, the only community health center in Florida to operate a HRSA-funded teaching health center. In 2018, CHI served over 83,000 unduplicated patients, totaling 289,000 patient care visits. We're not a mom and papa operation, folks, and we all need to take great pride in the fact that we are impacting the health of so many people in our communities. Something new I want to talk about this morning, because I want each of you to be involved in, and that is the fundraising program for CHI. We have not done this in the past, and I don't know of any FQHCs that are doing this. We are focusing on two programs: an annual campaign and a capital campaign. The capital campaign that we will be launching very shortly has a goal of $5 million over 2 years. And this campaign is to support the construction and operation of our Children's Center, which we hope to begin groundbreaking this year. $5 million in the scheme of things is not a lot of money. It may sound like so today, but when you look at the philanthropic community in Miami-Dade County, FIU has a $750 million campaign. University of Miami have raised millions of dollars, billions I should say, in their campaign. So little old CHI is just asking the philanthropic community in Miami-Dade County to support us with a $5 million campaign. You know, when the campaign was on for the Martin Luther King Memorial, CHI employees contributed $20,000 for the Martin Luther King Memorial. Some of us gave cash, and some of us just contributed some PTO time. So, to facilitate all of us participating in our fundraising campaign, we are going to urge those people who can to donate some PTO time for our capital campaign so that we can build that children's crisis unit. I always, when I speak on General Care Team meeting, I give you an opportunity to ask questions. Today, I'm going to ask you to hold your questions until all of the staff has presented, and then we will entertain questions from everyone who desires to ask questions or to make a comment. Thank you very much.
Good morning, everyone. Are we awake? Yeah? That doesn't sound awake. Not for CHI, anyway. Good morning, everybody. It's a little bit better. I just want to take a minute and say good morning also to those of you who are joining us from a live streaming service. We appreciate you joining us. So, one thing I'd like to say about today is that today is about education. So, from this point forward, all of the senior staff who come up here and speak shouldn't talk for more than 5 minutes. Sound good? I see a couple head nods. We want to stay here longer? Yeah? Okay. All right. So there are a couple things that I want to talk about. Is the three things. CHI has a disaster plan, advocacy, and then I have another question about why. So everybody knows that CHI has a disaster plan, right? See some nods, I hear some yeses. Can I see a show of hands? Almost everybody, more hands. Okay, we're still a little tired from the weekend, had a lot of fun. All right, so yes, CHI does have a disaster plan. It's called the COOP, or the Continuity of Operations Plan. And this document actually provides us guidance before, during, and after a disaster to make sure that CHI's employees and patients are safe and that our security of our facilities and equipment is intact in place. So does everybody here have their own disaster plan? I see some yeses. Does anyone here not have a disaster plan? Maybe that's a better question. No? Nobody? I saw one hand. Don't have a disaster plan. Okay, so we are first responders. We all know that. And we can't help the community if we're not prepared. We all agree to that? Yes. Okay, so make sure that you have a disaster plan. Make sure that your family has a disaster plan. If you don't have a disaster plan, and this is for anyone who might have been shy not to raise their hands, make sure you have one today. Make sure you have at least a 3-day supply of necessities for your family. You might be surprised. I remember when Irma came through, some of us needed more than 3 days supply, right? We all know what it feels like to go to Publix and see the aisles of water completely empty, right? Make sure you start early. Make sure you have cash. I'm sharing all of this with everybody now because what? It's hurricane season, correct? Okay, so if you haven't gotten out and already gotten some of your disaster stock, make sure that you do that today. So the last thing I'd like to mention about our disaster plan is one thing that's been really popular over the last 2 years or so is storm surge. Everybody heard about storm surge? Yes? Okay. The storm surge is really most important over the last couple of years because the storm can come through, and the storm surge, depending upon where you live, an elevation in Miami-Dade County can make a big difference as to whether or not you should get out or you're actually going to be safe at home. So make sure you know your home storm surge planning zone. I actually live in storm zone A. I believe Doris Eisen Health Center is in B, okay? So a couple things I want to share about the improvements that we've made over the last couple of years. I'm very happy to say that most of our centers now have hurricane shutters. Have some of you seen them go up recently? Yes, I see a lot of hands. I see some nods. So that was due to a federal grant that we were able to get. We also purchased a 4,000-gallon fuel tank for the generator at the Doris Eisen Health Center, which will allow us to run the entire facility for several days. That was a great win for CHI and for the Doris Eisen Health Center. Next item here is the Martin Luther King Health Center is getting a generator. Good thing? Yes? Yeah? Okay. Something else that we learned over the last couple of years is that there's obviously a need for increased communication, and so we've done that several ways. We utilize satellite phones. We obviously participated in text messaging, and we even tested a couple apps over the last couple of years and the ability to communicate with each other. All right, I'd like to move on to advocacy. So just a couple things here. Remember that we do need your support. CHI is partially funded by grant dollars, correct? We all know that? Anyone know the agency that supports us with grant dollars? The Public Health Trust. Public Health Trust does support us. HRSA, I saw it somewhere over here. It's the Health Resources Services Administration, okay? Now this week, House leaders are actually set to vote on a $1 trillion five-bill spending package, and it comes at the form of an omnibus or a minibus or some kind of bus. It doesn't even matter, to be completely honest. But what I need from you is to make sure that of the many different bills that have been introduced to support community health centers, to make sure that you all actually get out there and support. So when we ask you to make calls, to do social media, to do text messaging, so Facebook, Twitter, anything else that's out there. When we ask you to contact our elected officials, members of the House, the Senate, please do it. And that might come at the form of a very simple email from Mr. Peter Wood, our Director of Planning and Development, or Romanita Ford, or myself. When we send out an email to ask you to contact our members of Congress, please do it, because it is vitally important to community health centers, especially CHI. Now, there is one thing that I would like to mention for the Teaching Health Center program. Can I see any of our recent graduates or the members of the Teaching Health Center program? Anybody in the house? How about a round of applause for them? So let me tell you about advocacy for the Teaching Health Center program, just very quickly. There is potential out there to reauthorize funding for their program for the next 5 years. And what that could mean are new teaching health center programs in the state of Florida or throughout the nation. But it also means up to 250 new resident slots by 2024. So when I say that we need your support, it's to help build the pipeline of providers that's going to serve our patients in the community. That's across the nation, so please do support them. So the last thing I want to mention before I get off the stage is that I want to ask, does anybody here know why CHI exists? And just shout it out. You know, why CHI exists? Anyone? We all shy because it's Monday? It's not a trick question. Access to high quality care. Here's another question that might help us answer why does CHI exist. What does CHI do? I'm sorry, say it again. Serve the community, provide care. Exactly. So CHI provides health care. But when I ask you why does CHI exist, at the core of it all, we exist to make people feel better, right? Right? Does anybody disagree? At the core of it all, we exist to make people feel better. So folks who have probably had the worst day of their lives are walking into the center, they're typically low-income patients, and they just want to feel better. But what CHI actually does is that we provide patient care, right? Or that's what we do, I'm sorry. So for members of the care team, that's easy. We do family medicine, oral health, behavioral health, dental, radiology, vision. We do all of the services. That's what we do. But we exist to make people feel better. So I want to ask each one of you, what do you do for our patients on a daily basis? And when you think about that, it's very simple to do simple things, such as the 10-5 rule. Everyone remember the 10-5 rule, right? Within 10 feet, smile. Within 5 feet, you speak. A smile is something very easy to do, and it's very simple, and it can make people feel better. So please, as you go on day to day providing excellent service to our patients, remember to think about what it is that you do on a daily basis for our patients. So the last thing I'd like to mention is that the CHI family, honestly and truthfully, is the best. Everyone believe that? Yes? How about a round? Yeah, exactly. Give ourselves a round of applause, please. And when I say this, I truly mean this, that we are among the top community health centers in the nation. Know it or not, believe it or not, I'm here to tell you, you better believe it. Of the 1,400 health centers out there, when we have the opportunity to go and see other community health centers to see what they're doing and the impacts that they make, you all are truly rock stars. You're rock stars of the health center world, okay? And so I want to make sure that you know that, believe it, and tell other people, okay? Three stories I'd like to mention real quick. These are very brief stories. Anyone else go to Publix where shopping is a pleasure, right? It is? Okay, so from time to time I go to lunch and I go there to get a sandwich or a salad or something, and I wear my name badge, right? I never take it off because I'm at lunch. And this one day, and I apologize to some of you who've heard this story already, but I got in line to pick up my salad and my drink, and the cashier saw me, and this is my neighborhood Publix, it's right down the street, but she saw me, and she sees me all the time because my wife has me shopping for our 3 kids. And she sees me, she recognizes me, and she says, "Oh my God, you work for CHI?" And I said, "Yes, I do." And she said, "You know what? When my family came here 15, 20 years ago, I don't remember the exact number of years, she said, my husband had cancer, and we came to the country, we didn't have insurance, none of us had jobs, and he was sick, didn't know what to do. She said, I came to CHI, and he got cared for. I believe it was by Dr. Oprah, but she said that it made such an impact on their family. That was really meaningful to me. And if you know anything about Publix, they train their folks to, check these people out and get them running, right? Well, she stopped. And so as she was sitting here telling me this story, she stopped checking me out. There was a line walked up behind us. And so I know that the work that we do is very meaningful. At least it was to her. And so I know that there are several other stories out there like that. Second story is, I just want to mention, is Jonathan. He's PFSS at Doris Eisen in the audience. I thought I saw him. There he is, right there. So I just want to mention this briefly because I think it was really cool. So if any of you have been to Doris Eisen and in family medicine, when I asked that story, or when I made that point earlier today, I wanted to ask you, what is it that you do on a day-to-day basis for our patients? Jonathan, as I was told, actually takes money out of his pocket and he gets these colored pencils. And so he gives these pencils to the kids who come in through pediatrics while they wait. That's cool, isn't it? Let's give Jonathan a round of applause, please. And I'll give you a brief example of how I know this, because one of my kids was sick the other day, and he comes through family medicine, and my wife is there with our other 2 kids. I actually have a 6-year-old and 4-year-old twins. And my wife tells me, she texts me, she says, I'm here. So I walked over just to say hi and everything, and it was quiet. Anyone has a 4-year-old and 4-year-old twins and a 6-year-old, they're running all over the place, right? My kids are like hanging from ceiling fans and all kinds of stuff. And so it was quiet in there, and they're all sitting here coloring. Daddy, look at this picture, look at this picture. So I thought that was really cool. And then what I found out later was that some of these kids, when they come back, they see their pictures posted up next to them. And they said, I did this picture. That's really cool. So I did want to share that. Last story I want to mention really quickly, and then I'll come off. And Tiffany, I apologize if you were going to share this, but did any of the ladies go to the women's health event that we had recently? Some of us? Okay, excellent. Well, I want to thank you all for coming out. And I do want to thank the ladies because it was an excellent women's health event. If you missed it, hopefully you come out to the next year's. But what I found out was there was a middle-aged woman who attended the event, and she said that she came up to I believe Beverly, and actually said that, you know what, thank you all, thank CHI for having this event. I said, okay, well, why? Said, I wanted to do something for my mother for Mother's Day, but couldn't afford to. So I brought her here to the CHI Women's Health event. She was in tears, was able to give her mother a massage, got her nails done. She even got a rose from a firefighter. I have no idea what the firefighter was doing there. But those are the types of things that make an impact on people, okay? And going back to what I was saying earlier, we're here to make people feel better, regardless if you're driving a vehicle, if you're writing grants, if you're cleaning up areas. We're here to make people feel better. So I want to share those 3 stories with you on the heels of telling you all that you're all rock stars at CHI. And last thing, I do want to ask you all to please join us for the Men's Health Fair this Thursday. We're going to have a terrific time. We've got a lot of great giveaways to give out, and hope to see you all there. So thank you very much. Dr. Mofa?
Good morning, CHI. All right, not bad, not bad. Thank you so much, Blake and Colonel, for those very inspiring and encouraging comments. CHI seriously has name recognition across the country, and just listening to you, I really felt proud. And I want to say thank you for that. And all of this because of what you all do. You know that we take care of about 800 to 1,000 patients every day in CHI, and we continue to hear such positive comments on these patients, and we thank you for that. Patients are telling us that they're able to get through on the phone much better, they're able to get an appointment way better, they're waiting less than they have, but most importantly, they are exuding a sense of the warm, fuzzy feeling we're providing much better than we have. And so for that, we want to say thank you. So we do have a lot of things to be grateful for. I want to say thank you to our clinical leadership at this point. I mean, thank you so much for helping us in moving all of these patients, ensuring that they're providing evidence-based practices that make a difference in the patients' lives. And that takes no small feat, so we appreciate that. Just a couple of very quick recognitions that I want to sadly underscore here. There are a number of you who were involved in the Black History Month, and I want to say thank you because I don't think we've met since that time. There were those of you who were involved in marketing, the outreach, Tiffany and Eunice, but my favorite, Beverly Hepburn, is she here? Beverly here somewhere, probably doing what she does best. Thank you so much. Sorry, Tiffany, but she's my favorite. Okay, all right, great. That's one thing we can agree on. The passion you put behind that effort was really amazing. And we thank you for that. IT staff came out on Sunday setting up the podium and stuff. That was pretty cool. And all the outreach staff, we thank you. But I want to thank particularly our speakers, our providers, our residents who came out to speak on a weekend, knowing that it takes a lot of preparation to present on a pulpit in front of a church group. That's not an easy thing to do. And I want to thank all of them. I'm not going to go through the names, but we really appreciate you doing this. And I think with this effort, you're volunteering to continue to do this every time we ask of you to do so. So thank you. There are a number of other folks who've come out to do television shows and so on. We'll certainly recognize you at different times. But at this time, I want to say thank you to those of you who came out during the Black History Month because with the Colonel's direction and vision to going into the churches to present on topics of importance, it took a lot of nerve and gut to do so, and it was really well received. So we thank you for that. Just a couple of quick comments. There are 2 clinical intervention programs in CHI I want to mention because many of you are our patients. There's a Target BP effort with a goal to improve blood pressure control. And many of you are patients with hypertension. Please remember to have your blood pressure checked. 130 over 80 or above is not okay anymore, okay? And we know that there's so many different things we can all do to improve blood pressure. The MAs repeating uncontrolled blood pressures, the providers being very assertive in blood pressure management, the nurses doing the nurse-run blood pressure clinic so patients can come in outside of a visit to check their blood pressures. But take advantage of that, okay? As we go through charts, as we go through visits, we realize that a lot of the patients with uncontrolled blood pressure are you guys. And it's painful for us that we focus on everybody else except our own staff. Colon cancer screening for those of you, not me, who are older than 50. We have a number of programs in place. Make sure you get your colon cancer screening. We give out these fit kits. They're very easy to do, but take advantage of that, okay? And if you have not had your colon cancer screening, talk to one of us, and we can make this happen for you. All right, as always, I talk about productivity and quality, and I wanted to talk about wait time. I'll just allude to it briefly. I had too many slides, and Blake threatened me, so I'll keep it short here. But we want to thank you for what you did last year. Difficult to see from where you sit, but for every, the blue columns are the encounters for 2018 per month, and the red for 2017. Just notice that for every single month last year, the blue exceeded the red except December. With less staff, providers, support staff, that was pretty impressive. Every single month, we had about 1,500 to 2,000 additional encounters from you guys, and we thank you for that. We certainly are not where we wanted to be, like Mr. Hadi said. We want to maximize patient visits every single day. So we do have some work to do and some work to do this month, this year. We always like to compare and see how we're doing across the board. We want to look at which site probably contributed the most to how we did last year, but especially this year, okay? And this just looks at the expected productivity for the providers in that site, okay? And out of that, to what extent are they meeting those encounter goals? So let's look at what each center, each site did. And it's, again, anybody who hit above 80% is in the green, and down to 60% or above that in the yellow. So it's difficult to see. We email this out every month, but you will notice that the winner, or for productivity, year to date so far is West Kendall. Is West Kendall here? We thank you for exceeding goals almost every month. Okay, because with time off, we expect each month we hit about 85%, but they're way out there for most of the month. And when we average it out, West Kendall really is doing very well. Also, Everglades and West Perrine and South Day, you in the house? We thank you for your work. What you don't have on here is Hallway 4, and as you know, Hallway 4 is always above the goal, so just want to mention that. What about departments? We also able to look at that by department. Again, looking at the department's capacity, and out of that, how they're performing. And so looking at the capacity that each department has, which department is actually exceeding encounters per the capacity, is actually OB. So we thank you so much. We don't have enough providers, enough staff, but you guys still manage to make the encounter goals. And we appreciate that. And then followed up by family medicine. So thank you all. We're not where we're supposed to be, but I think year to date, we're getting there. We don't want to leave our residents behind, and again, we're able to get the data by the residents groups as well, and the site residents are really exceeding goals here. Any site residents here? Somewhere in there? No? Okay. We thank them for what they're doing. They actually have the better productivity capacity so far. All right. What can we do differently over the next 2 months to make a difference? For every one of us, let's remember, making that patient experience excellent is key. That warm fuzziness is the biggest driver of our encounter volumes, and every single one of us can make a difference. From those of you driving your patients in, to the reception folks, the security folks, our logistics staff, to the nurses, to the providers, administration, to those who handle phone calls. That warm fuzziness makes a difference, and we ask you to continue to do that. The patients don't come here because they have nothing better to do. They need our help. And if we choose to work in this industry, let's do all it takes to put aside our home difficulties and issues, and when we come out to give out our best. It doesn't show in here, or I guess it's okay. The front desk, please make sure that we get to see the first patient on time. The nursing staff, we're asking you to make sure that your visit preparation activities are full and complete. The providers maintain a sense of urgency, never turning away any patients. And if we all do those kinds of things, we can keep getting the patient visits where we want that to be. What I have on here is something Mr. Harley always reminds us of, not very visible on that slide, and it's that there's no romance without finance, okay? What about quality? Difficult to see, but every one of you should have seen this data. I just want to give you a visual that shows us we're doing well in some places and not so well in other areas. What you'll see on here that our Naranja site continues to excel when it comes to quality indicators, and we thank you for that. We'd like to encourage our Marathon, our Coconut Grove, and our West Perrine sites actually to actually work on specific areas that we'll be talking about. This is something we email to everyone, so hopefully you take a look at it and see where your site is and the things you need to focus on. A few areas we want to focus on for the rest of the year: diabetes management. We want to get most of our diabetics at 20%. We want to get less than 20% of our patients with their diabetes controlled or their A1Cs performed, okay? And that should not be too difficult to achieve. We're currently at 30.8%. What it means is that if we manage to maintain where our existing patients are, but improve diabetes management in just 700 more patients, we can actually get to this goal. 700 patients we're talking about for our 50 primary care providers and residents. It comes to only about 15 patients per clinician. That is not difficult, is it? Just 15 patients. If we did that, all things remain the same, with no patients getting worse, we should be able to achieve that. 85 patients for blood pressure management. We're talking about, what, 5, 6 patients per provider? That's not hard. Colon cancer screening is has higher numbers, but we know that we can achieve that. I imagine that if we got all of you who are patients over 50 to achieve a colon cancer screening goal, we probably will bump up to maybe 38%. But for this 1,200 additional patients getting those fit kits, getting a colonoscopies, we can achieve that. And we're talking about just less than 100 patients per clinician, per care team. That must not be difficult. And the same thing with PAPs, right? 10 more PAPs for everyone over the next few months will get us there, assuming that some women don't fall off compliance, okay? But look at these things not just for the numbers, but these are patients' lives behind all of this. You're not doing this because Allison says you should, or because the Colonel and Blake are asking us. This is about patients' lives. For every single patient who comes through whose fit kits we don't give out to and track, what are we saying? We don't care about them? I don't think we're saying that. And I know sometimes in the hustle and bustle of what we do, we omit some of these things. We're asking you to pause sometimes and to pay attention to the fact that you make a difference in people's lives. And one woman who ends up with cervical cancer because we didn't pay attention, you're talking about a whole family that's going to be messed up, in addition to this person who's going to suffer. And it cannot be. All right? So we ask you to please pay attention to this and do this not for us in leadership, but because it's about saving lives in the profession that we chose to be in. What should we focus on? Diabetes, hypertension, cancer screening, cervical cancer screening, and we also want to do a better job at managing our high-cost patients, something we'll be focusing on with our managed care staff over the next few months as well. We know that if we do that better, not only do we save patients a lot of hardship, but we're able to generate revenue for CHI. Now, a number of you walked up to me this morning and kind of nudging me on. Are you going to beat up on Blake today? And I thought, come on. Blake and I have a truce, and as a gentleman, and as he is, I'm going to back off of him. But it didn't mean I was going to back off of everyone. I mean, come on. That's just my nature. I just cannot help it. And so let's just have some fun for just a second. And great, you can see it up there. I'm going to project a picture, and I'm going to ask for the best caption to win. I am going to give you, okay, whoever wins with the caption, a $25 gift certificate. I'm actually going to give 2 of them. The only thing is that hopefully everybody has my cell phone. That's public information. But you can only text me between 12 and 1. I do not want you to get distracted with the rest of the presentations and the training we're going to have. Between 12 and 1, you text a caption, and if you win, I will text you back and let you know. And if it's okay with you, we'll share with all staff. So this is the picture. So just in case you can see clearly, this is certainly you know who, no names, we have to be confidential. But this card here is a Trump-Pence re-election committee membership card only if you contribute significant amounts, at least $10,000, okay? Then you get one of those cards. I happen to know that it was actually more contributed in this case. So what I'm asking you to send me is a caption that describes this, you know, and be creative. Like, no, I won't give you any hint, but how about that? Between 12 and 1, please do that. Let's have some fun with it, okay? And don't be scared. Mr. Harley is a trooper, and, you know, he will be okay with that. I intend to post this in a few places where the captions are. We won't have to put your names to it, so don't be scared. But let's have some fun with that, okay? Mr. Harley, is that okay with you? He said okay. Very good, very good. So now that I have your attention, I want to end with a few closing comments, take-home messages. Let's please work to maximize all providers' schedules, okay? Don't turn away patients, please. These are patients coming here because they need us. Please make sure that we focus on cancer screening and those chronic diseases management over the next few months, again, because we want to save lives. Please remember, you came into the healthcare profession because you want to make a difference, and it's a privilege to get to do that. Not everyone has that privilege, but that privilege comes with responsibilities to take care of the patients who come to see us. So as we move to 800 to 1,000 patients a day, let's focus on all the things that the leadership tells us, but primarily I'm asking your cancer screenings, the diabetes, hypertension, especially in yourselves. Let's make sure we do that so that we can continue to save lives. And with that, I want to say thank you so much for your attention, and I appreciate that. Monica?
Good morning, CHI. I'd just like to spend a couple of minutes with you and give you a few updates from the nursing department. Staffing changes, next please. So I'd just like to announce a few of the staffing changes within the nursing team. At our Marathon Health Center, our current site manager is Rick Henderson, RN. Rick has been with us for more than 10 years, and he is planning on retiring real soon. We've already onboarded a new nurse. Her name is Tara Barnes, and she will be starting with us tomorrow. So Tara will be the new site manager for Marathon. At our Tavernier Health Center, Kim Tate, which is the RN that's there, is now our RN 3 site manager for that location. Our nursing services coordinator, the RN 4 position, is now occupied by Ms. Shantae Johnson-Pierre. Our education department will have a clerk effective today, Margarita Melo, which is a PCT in family medicine. So you can now find her in the education department. And for our school-based department, LaQuise Tuff is now the clerk for that department. Next. So we continue to have ongoing nursing strategy meetings among the leaders to discuss opportunities and strategies for workflow improvements. These meetings have identified staffing needs and areas for improvement. So as a result, decisions were made to begin utilizing our medical assistant trained PCTs more productively. Our first step was to initiate refresher courses focusing primarily on injections, wound care, respiratory treatments, administering and reading PPDs correctly, preparing and giving oral medications, and the safety measures for all of those skills. We had our third or fourth class on this past Saturday, which was well attended. One of the goals is to maximize the skills of the staff, and I will be echoing a lot of what Dr. Mofa just said. Allowing the nurses and the MAs to function at the top of their clinical license and certifications. Next, we want to empower and motivate the team to utilize critical thinking skills and hands-on experience with the patients, therefore allowing the team leaders, which are our nurses, more time to manage and provide quality care coordination. So this transition is ongoing, and the site managers and the team leaders will be sharing more information with their teams as we progress. Next, I want to say thank you to our school-based team. And can I just have the school-based team stand for a minute, the ones that are here, all of them. School-based team. Okay. Thank you. You may have a seat. So, we've successfully completed our 2018-2019 school year. Their last day will be this Friday. We have 35 schools assigned, and the team consists of mental health professionals, which are comprised of 8 MSWs, 4 LCSWs, 3 health aides, which are PCTs, 23 LPNs, 16 RNs. We're also located at Homestead High School. We have 1 PCT at that health suite. Our Cope South Center, we have a physician assistant, 1 LPN, and 1 PCT. And as I just mentioned, we've replaced our clerk. And our program manager, Ms. Vivios Gustav, which is our Nurse of the Year. So let's give her a hand for that. So I just want to touch a little bit more on productivity and wait time, echoing a lot of what Dr. Mofa just said. So productivity and wait time remain our focus areas for the organization. Strategies to improve productivity include certain roles of the nursing team. So completing pre-planned visits, ensuring pending results are in the patient's charts at the time of the visit, increasing our patient supply by maximizing the provider schedules with appointments and walk-ins, completing daily huddles. That's very important that we get those huddles in. I know it's a challenge at certain centers, but we've got to strive to make sure that task happen every day at all of our centers. So we want to assist the providers in decreasing their work volume by ensuring the nursing team is practicing at the top of their license, which is why we're doing all of the training to prepare our MAs to do that. We want to assist the providers maximize the hours at work by starting on time, making sure that patient is in the room at 8:30, and minimizing provider distractions. So I really need my team to be a little more front and center and making sure that the providers stay on task and not be distracted. I know it's a challenge on Highway 4 with Dr. Mofa, I've been hearing, but just keep working at it. So as a team, we are all accountable for productivity and wait time. We all play a part. It takes teamwork, communication, and collaboration to achieve our goals. As an agency, our ultimate goal is to increase encounters and sustain financial stability. Working more effectively will contribute to wait time being diminished and achieving positive patient outcomes and experience for our patients. So with that, I'd just like to say thank you, and yes, the nursing department rocks. Mr. Pierre.
All right, good morning, CHI team. How are we doing? All right, I promise to keep mine very brief. This morning, I want to just talk to you briefly and give you a 1,000-foot overview on a new initiative that we're getting ready to move forward with between behavioral health and primary care, and that is our Medication Assisted Treatment Program, also known as MAT. So what is MAT? MAT is an evidence-based program or practice that combines pharmacology, interventions with substance abuse counseling and social support, okay? So we recognize addiction is a chronic relapsing disease. Some substance abuse counselors and administrators have been reluctant to embrace new technologies for its treatment. But we know on a national, state, and local level that the opiate addiction problem is now an epidemic, and we want to do our part as a community health center and move forward with establishing this service that our community desperately needs. There are 3 drugs that are approved by the FDA for the treatment of opiate dependence, as you can see above. All 3 of these treatments have been demonstrated to be safe and effective in combination with counseling and social support. So in addition with the medications, that client will be receiving psychotherapy and also social supports. Due to the chronic nature of the OUD, the need for continuing MAT should be reevaluated periodically. There's no maximum recommendation during the maintenance treatment, and for some patients, treatment may continue indefinitely. There's funding available through FATA. There's funding available through South Florida Behavioral Health Network, and of course, HRSA has funding for this specific initiative. The state of Florida actually has an opioid state targeted response program, and you can see some of the statistics there, which include reducing opiate-related deaths, preventing prescription opiate misuse among young people, increasing access to medication-assisted treatment among individuals with opiate use disorder. Just some interesting facts that I pulled from the CDC. More than 6 out of every 10 drug overdose deaths since 1999, okay, have involved opioids. Florida ranks 4th in the nation in total health costs attributed to opiate abuse. Once again, Florida ranks 4th in the nation, so we're pretty high up there. The Miami-Dade has actually initiated a task force, and the commission approved an ordinance sponsored by Chairman Bovo to extend the life of the county's own opiate addiction task force. Okay, the mission of the task force is to identify solutions through a comprehensive opioid addiction action plan, including community-based and other strategies to combat the epidemic. Now, CHI will fall in alignment with the county's task force, and the main goal of the program is to implement and reduce and prevent opiate addiction, preventing overdose, and improve the social economic quality of life in Miami-Dade County. We'll have several stakeholders, which will include the justice systems, and we will want to raise awareness toward the misuse and dependency of opiate among our youth. So what are some benefits that we hope to achieve? We want to decrease risk of hepatitis C and HIV transmission, decrease criminal activity, as well as becoming victims of crime. For pregnant parents, we want to decrease the low birth weight, premature birth, improve retention and treatment, and decrease relapse rates. And the overall #1 goal is to decrease risk of death. And we hope to pilot this program and get it off the ground at our Doris Eisen Center in the next quarter. So I just want to give you a brief overview. This will be, once again, a joint effort between primary care and behavioral health. And that concludes my presentation. Thank you so much.
Good morning, everyone. Great to see you all. I'm here to talk about what do you say about CHI? So you all are ambassadors in the community, and when you're out in the community like Blake at the supermarket, what do you tell people about where you work? I think there's one group here that really knows what to tell people. That's the outreach team. Can you guys stand up? I'm really proud of the work these ladies have been doing lately. They've been really pushing the pedal to the metal and working hard to increase their metrics and going out and bringing in new patients. And they're doing that through sales techniques and messaging. So I want you all to join on the bandwagon and use some of that same messaging. I'm going to give you the core principles because I think it's really important that we're all kind of singing the same song. So what should we say about CHI? No, go back. Okay. Community Health of South Florida, CHI. It's important that you say both Community Health of South Florida and CHI, because some people might know CHI, or some people might know Community Health of South Florida, but not know that we are one and the same. It's a nonprofit healthcare organization. Healthcare organization. Nonprofit. People don't necessarily know those things. We've been serving the residents of South Florida for more than 45 years with comprehensive, compassionate services for the insured and the uninsured. Believe it or not, there are still a lot of people that think we only serve the uninsured. That's not true. A significant portion of our patients are insured. So it's important to tell the community that we have a good balance, a good mix of people who have insurance as well as those who don't have insurance. We offer a sliding fee scale based on their income. We make healthcare convenient so that you can take care of all of your needs in one place. For example, CHI has primary care, pediatrics, behavioral health, OBGYN, dental, urgent care, pharmacy, radiology, laboratory services, vision, and more. We even offer free transportation to and from appointments and free prescription deliveries. If you don't know these things, go on the website and educate yourself, because as I mentioned, you are our ambassadors, so it's important that you're saying the right things to our patients out in the community, as well as our patients when they come to see us, because remember, we're also doing cross sales. You should be suggesting 3 other services when they're here and trying to book those appointments for them. Next slide. Okay, we often have members of the media coming to Community Health of South Florida. We've had international news coverage as well as national news coverage, so it's important that you guys know what to do with the media. Anytime a member of the media calls, you should direct them directly to me. You can give a member of the media my cell phone number. Don't give it to patients. I know some people have been giving it to patients. But if it's a member of the media, their needs are urgent, so please give them my cell phone number. Never answer any questions from the media or agree to do an interview without consulting me. Some of you have done interviews, and you know that we practice ahead of time and make sure that we get our messaging right. It's important because I screen the media calls before we allow them to come here. So please, don't say anything, because I need to do that screening and I need to make sure the employee is prepared to answer the appropriate questions. Also, if you see a member of the media just walking around inside our health center unattended, something's not right. You need to call me, you need to call security. That shouldn't be allowed. They should only be here if they're accompanied by myself. Next slide. Okay, I don't know if you guys have noticed, we have a new logo. It's kind of hard to see down in the bottom of the corner. We took off patient care comes first. It doesn't mean that patient care comes first is not our motto and it's not crucial to everything that we do. It is. We wanted to use it independently of the logo in our marketing and branding. So this is the new logo. It doesn't have that on the bottom, so I need everybody to go in and update their email signatures if you haven't done so already. Also, I want to remind you to never create any flyers or postings or anything like that without getting approval for how the logo looks on it. Please send those to me. I'm happy to help you with those. And then also I want to remind you that we have, if you're not using the print shop at CHI, where's Franz Germain? Franz. He works hard. He's a one-man show in our print shop, and I'm so grateful to him. Thank you, Franz. But sometimes there's the need that we have to print things outside of CHI. Anything printed with the logo on it and outside of CHI, we should be using these 3 approved vendors because we know that the quality is there for our logo, which makes our branding more consistent. Those are Minuteman Press, Go Green, and Southeastern. And Sharon DeMar Fletcher can help you with that contact information should you need it. Lastly, I want to talk to you about social media. You guys should be participating in our social media. I hope that you've been paying attention because we've been doing a lot of neat stuff. We have videos there. Sometimes we do live things. Sometimes we do interviews with some of our providers. So it's important that you share those posts and that you comment and you are engaged. We have Facebook, we have Twitter, we now have Instagram, and we have YouTube. So please get involved and support us. Thank you.
Good morning. My name is Jeremy Radzowitz. I'm the VP of Finance for Community Health South Florida, and today what I'm going to go over with you are the strategic investments that CHI has made over the course of the last fiscal year. So I've broken these up into two categories, systems and people. And first we're going to go over systems. So one of the biggest complaints that CHI had received over the last 5 years has been their phone system. The constant drop-in of calls, the inability to dial out. And so what we embarked on was a $1 million investment into updating not only our phone system, but also our Wi-Fi network, also our computers, peripherals, and monitors. Basically, our systems were about a decade out of date, and we've updated them so that they would be current through the year 2020. After we have completed that, as of December 2018, we looked to move on to the next phase, which was to address the inability for calls to be answered. So we redeveloped an internal call center. We dedicated about $265,000 to establishing it. On April 1st, that call center went live, and since then, that call center has fielded over 10,000 calls with about a 4% abandonment rate. So we're really proud of the success of this internal call center. It was headed by our Director of Patient Services, Sandra Reyes, and we only look to improve from there. The next investment that we made was in patient engagement. We had a hard time communicating with the patients, and we had a high no-show rate. So what we did was we invested in a patient engagement software called Solutions Reach. This software allowed us to not only send out appointment reminders, but also let patients solicit us for requests as well, issue them surveys after every visit, as well as allow them to refer to friends. This system went live on April 15th, 2019, and since then we've confirmed over 13,700 appointments, and we've received over 563 Net Promoter Reviews. We've also had 206 appointment requests through that system, and we're only scratching the surface of the potential we can do with this. The third system we have in place is, I call it physical assets. That's my accounting background. Essentially, this is any tangible goods that we have bought on behalf of the organization, and this includes dental sterilization, OB sterilization, dental equipment, the hurricane preparedness that was mentioned earlier by Blake, including the generators and the shutters, structural and visual enhancements. As we know, we haven't been able to do any visual enhancements or structural enhancements over the last 5 years. So we embarked on a new project to not only update the looks of our health centers, which you'll be seeing rolling out, but also you may have already seen some of the early phases of that with the hedge fence that we've put up at Doris Sison, as well as some of the other areas. We've also increased parking capacity. As I'm sure you already knew, Doris Sison had that already, but we've also increased capacity at our South Miami Health Center, West Kendall Health Center, and we're currently in the last stages of our Naranja Health Center as well. When we looked at our vehicle fleet, our vehicles hadn't really been updated in over a decade, so we invested in 8 new vehicles total, which included maintenance vehicles, employee transport, and patient transport vehicles. When we look at the people, first place we need to start is fringe benefits. So in 2018, CHI invested over $7.4 million in fringe benefits for their employees, of which almost half was the health cost. In 2019, we're anticipated to spend over $3.5 million in healthcare alone. As we know, with the times, there's a rising cost of healthcare, and CHI had a choice when they received their new healthcare premiums to either pass it along to the employee or to eat it internally. And what CHI decided to do was they were going to absorb the full cost of that, so the employee saw no change in their healthcare premiums. Additionally, CHI invested over $1.1 million into the employee's 401k funds, regardless if the employee contributed or not. As you all know from the last General Care Team meeting, CHI participated in a uniform allowance on March 8th that was distributed to over 462 employees, and it cost the organization over $43,000. Since then, CHI has embarked on a new internal uniform committee to look to see if we can leverage economies of scale and update the look of our uniforms as well as make them more affordable across the system. Training and development. In fiscal year 2018, CHI spent $106,000 on training and development. And this year alone, in the first 7 months, we've spent over $120,000, and we're going to be spending even more. I'm a big proponent of training and development. It's the only way that we can enhance your skill sets to get you ready for the job for tomorrow. And I got to applaud Monica for her initiative in the medical assistance training, Sandra Reyes for her new onboarding of front desk staff, as well as the fact that we're now looking to enhance our on-site areas with a new EHR trainer spearheaded by Dr. Amofa and Allison Madden. But when we add all this up, this is over $10 million of investments, $2.4 million coming from systems, and over $7.6 million coming from people. And that's the end of my presentation. Thank you all, and have a good day.
Good morning, CHI Care team. It is my biggest pleasure to stand here in front of you with my team to talk to you about our biggest asset. Each and every one of you are people. So what is HR working on so far? What have we been working on this year? We just wrapped up our 2018 performance evaluations. Your managers should be sitting with you if they haven't already to share with you how you performed last year. Just last week, anyone that was eligible for a merit increase received that merit increase in the June 7th payroll with a retro back to January 1st of 2019. What is the current state of our affairs? CHI, from an HR and people perspective, is doing better than it has in many, many years. Currently, we are averaging a monthly turnover of 14.1%, where our goal is 15%. We're doing so much better than even some of our other FQHCs in the state. Why is this happening? It's not Carolina and HR team. It's every single one of you. This is reflective of the work that you are doing today. Everyone has come up here and talked about training, retraining, onboarding, and all of the initiatives that are happening in the organization. And so I applaud each and every one of you for doing everything that you can to ensure that patient care comes first. And that we can continue to do that better with retaining our top talent, which is every single one of you. The last thing I wanted to address is ADP. My team and I embarked middle of last year, actually when I first started, on updating and improving some of the costs that were affiliated with human resources. We have upgraded some of our portal, our ADP portal. We are rolling out some of the self-service features to each and every one of you to have more control of your information. Nicole Holness on my team sent out an email advising you of the information that you guys can now access and update on your own. Always come to HR and we'll teach you how to do that. Effective today, we're going live with a paperless project, meaning all of your records, all of your files in human resources will now be electronic and they will be tied to your ADP record, meaning that a lot of that information will be visible to you once we conclude the project through your ADP screen. And that concludes my report. And thank you for everything that you all do every single day to ensure that patient care comes first.
Okay, now we want to open it up for questions. I see we have the mics on all rows. So if you have a question or comment, now is your time, and just head to one of the mics so that you can ask your question. Is there anyone with a question? We've covered a lot of information this morning from the staff, but we always want to give you that opportunity. Okay. Staff, I guess you've done a good job. There are no questions. Okay, we will go into our training sessions. I think you know by now where the training sessions are being held. Some of you are going to stay here and then others will go back to the health centers for training. Thank you so much for all you do for CHI and all you do to take care of our patients. Thank you very much. The meeting is adjourned.
Can we please remind the clinical staff to stay behind? We're referring to providers, nursing, pharmacy, lab, dental, behavioral health, school-based. I think that's what I have on the list. Okay? Providers, nursing, pharmacy, lab, dental, behavioral health, school-based staff. And if you don't mind, please coming forward. We would appreciate that. We're going to go ahead and start in about 5 minutes. We won't take a break. If you need to use a restroom, please, sneak out, come back in. Patricia, if you want to get ready. Are you ready? Do they have your slides? They have your slides, right? Okay, just make sure they have it ready.
Just a brief reminder, the PFS training is going to be a WebEx, correct, Sandra? It's online, so you have the details. There is a link provided in your email. Also would like to ask everybody to be safe on their ways back to the center. It is wet outside, so thank you.
Please take your seats. We will start in about 3 minutes. Would you please be kind enough to come forward? All of you behind the camera, can you please come forward? It's okay. We're not going to bite. All of you behind the mic, the camera systems, please come forward. Please move forward, people. If you're sitting behind one of the mics, please come forward. Those of you all the way in the back, can you please come forward to in front of the mics, please? All of you in the back, all of you behind the mics, please come forward. Maria, would you please help get everybody forward for me? Maria Montoto, please. Patricia, would you please get people forward for me? Thank you. So the last announcement, if you're sitting behind the microphones, we appreciate if you come forward. It's just, the instructions are that simple. You look to your side, you're sitting behind a microphone. We humbly ask you to come forward. Eliana, would you mind helping get those folks out there to come forward for me, please? They're all behind the microphones. Thank you so much. Thank you, Shante, for helping to bring them forward. For those of you sitting all the way in the back, the microphones are still in front of you. Please come forward, okay? Please listen to Eliana and come forward. The microphones are way ahead of you, please. Not those. Please, thank you. All of you sitting in the back, we'd appreciate you if you can come forward. Even if somebody sitting next to you is refusing to get up, you can do the same. You can move forward, people. All right, thank you so much. We're going to go ahead and start. For those of you who follow this instruction and move forward, we thank you so much. For those of you who refuse to do that, that's okay. So good morning, everyone. Can we please settle down? I want to make a few comments before we start. Thank you, Oleana. Thank you, Shante. Thank you for all of you who help move people forward. Appreciate that. Okay, we're going to go ahead and start. Good morning again, everyone. Okay, so we have a very tight training agenda for everyone today. Why are we here this morning? So we had a Joint Commission survey a few weeks ago. And while we did very well, we think, there are quite a few findings that came out. And we were required to provide staff training as part of a response to the survey. This afternoon, Alison and I will attempt to finalize and perhaps submit the report, but only if we've provided this training. We have this morning a number of people who are going to be presenting to you. Patricia is going to talk about infection control, Margarita Vega about immunizations, then Shante will talk about medication storage and handling, and then I will come and talk about pain assessment and management. Dr. Rivera will talk about task management and monitoring medications. And then Patricia will come back on competencies. I want to say thank you to Allison for putting together this amazing agenda. It took a lot, having to go through all the findings to put this together, and it was really very well done. So thank you for that. We also want to say thank you to all of you who are going to be speaking today. Some of you put together slides, some of you did not, but preparing to present to staff is always a feat. So we thank you for that work. Please remember that some of the topics will not be pertinent to some of you here. This is very, very intentional. You're going to hear about sterilization, and you hear about competencies, and you hear about vaccinations, and some of them will not be pertinent to you. But why did we ask all of you to be in here? Number one, there's some of you who move departments. You move from one department to the next, and we want you to hear about these things, okay? Secondly, I think it's important for some of you to know what others do. Oh, the dental staff have to do this too? Oh, the behavioral health staff have to do this? Do doctors have to do this too? So we think it's important that we all are aware of these kinds of things. So it's important that as we go through these, you don't tune out because it doesn't directly affect you. We think that if you work in CHI, you must be knowledgeable about what's going on in our clinical operations, and it's so much going on that we're going to ask you to do that. Now, if we find that too many of us are glazing and tuning out, we're going to have to ask questions and quiz, right? So just pretend to be paying attention, right? That way we won't come back with questions and a quiz and call you out to make sure you got information. So first, we're going to ask Patricia to come forward. She's going to talk about sterilization and disinfection. This is a very big deal for us. Please pay attention. A number of FQHCs have lost their accreditation because they didn't pay attention to many things, including some of the things she's going to talk about. And so you have the floor, and thank you so much.
Good morning, everyone. Everyone knows me. I'm Patricia, Director of Infection Control. I'm sorry, the light is bothering me a little bit, so I'm gonna be on the side. Okay, today I'm going to talk about high-level disinfection and also sterilization. It's a big deal for us here in at CHI because we do sterilization in OB and dental, and also we do high-level disinfection in radiology. I don't know if there is anyone from radiology here, but I invite them. I don't know if they're here. When we had our last Joint Commission survey, okay, we had some finding, and we did pretty good, but we have some finding that we have to work on. And I'm going to start with the high-level disinfection. In imaging, we have a trophon machine that we use for the vaginal probe to disinfect the vaginal probe after we use them for patient. I'm addressing that for OB and dental. It's information for you guys because maybe you don't know what the trophon is, but I'm not going to go in detail, just overview of what I'm saying. The trophon, we use it, like I told you, for high-level disinfection for the vaginal probe. One of the findings of Joint Commission was inappropriate documentation. They're very strict on documentation. We have 2 trophon in dental, in OB, in imaging. It's one, they have the identification. We have to identify them 1 and 2, okay? And when after we use them, we have to clean them and disinfect them. Everything that we do, we need to log. We have a log, we have to write everything in the trophon, from the trophon. It's because if there is any breaches, like any infection, any disease related to the photon, we need to be able to we need to be able to say which trophon we use and to go back to see what was the breach, okay? I don't know if you can see, this is the log that we use in imaging to document what we do with the trophon. We have the date of service, the name of the patient, the medical record number. Everything needs to be filled out in order to know when we use it and for which patient and which one we use, if it's number 1 and number 2. One of the findings was in the log, we have the space to put, okay. You see, this is the label that we have to use for the trophon after disinfection. One of the findings is that the technician wasn't writing the right the trophon, the number of the trophon that she was using, if it was 1 or 2. And there is a space for that. So you see, you can see you have the date, the disinfection, if it's passed or not, or failed, and the technician name, which is the initials, and also the notes. This is where she needed to put the number of the trophon that she used, if it's number 1 or 2. So here she corrected, she put 2, but like I told you, it's very important for us to know, like if there is a breach, so we know which probe to take care, to consider, okay? Now we're going to go to sterilization. I'm not going to go like deeply because we are, okay? We do sterilization in two departments. It's OB and dental. The finding that we had, it was about the workflow of the sterilization, how we do sterilization. We have a workflow from the point of use to the actual sterilization, okay? And can we go? This is the workflow, the correct workflow that we need to follow, okay? From the use, we transport, from the use of the point of use, we transport the instrument, we clean, we disinfect, inspect, packing, sterilization, and transport, and it's like a circle, okay? OB and dental, we're very familiar with that, okay? Now, the process starts at the point of use. That means where we treat the patient. And we need to keep the instrument moist. Now, before we are using like the Cavicide, that they said, no, it's not a good way to keep the instrument moist. Cavicide cannot keep the instrument moist. So temporary remove with the water, okay, that we put in the container, and we wet the water, and we cover the instrument in order to go to the sterilization room. Now we're going to move with the Empower solution, Empower foam, who's going to help us to keep the instrument moist at the point of use. And the reason why we're going to use it is because not only it helps with the moist, but also it's going to help us to start the pre-cleaning the pre-cleaning process. Okay. The Empower is already in-house. I believe we can start giving it to you to every size today, and we're going to have like a competency how to use it. I already sent an email to everybody involved in sterilization to go through it, and we're going to make it in practice, okay? And one thing which is very important is to keep the instrument open, okay? From the point of use to the sterilization, the instrument needs to stay open. Now, the Empower, to keep the instrument moist, we need to put them in containers. We have containers for dental and also containers for OB. And those containers, we have some regulation. They need to be closed, okay? In order to transport the instrument from the point of use to the sterilization room. And this is the one that we probably is going to use for OB, and dental already have them. The only thing that we need to put is the biohazard label on them, okay? And like I told you, per OSHA, those containers needs to be labeled, and also they need to be closed to prevent any leak or any accident, okay? Now, the second step of the sterilization is the cleaning, okay? The cleaning can be done manually and also mechanically. In OB, we do it manually, but dental, we have the ultrasonic equipment that we use. We had one finding also with this instrument that with this equipment, they didn't find the temperature. You know that when we use the maximize in that equipment, we need a temperature to check the temperature of the solution. We didn't have it. Now we're going to move to a new one. Like Jeremy said, there is some investment money. He put some money in sterilization, and we're going to buy this one, which is the one that we're going to use. If Dr. Watson wants to say something about it. So we're going to be able to monitor not only the temperature, but the time, the day, to open the log for that, in order to justify the use of those equipment. Okay, so if you do it manually or mechanically, the next step, everybody knows that the next step is rinsing. Before you can put the instrument in the autoclave, we need to rinse them. Rinse, dry, and pack, okay? So we have to follow the flow. We transport the instrument, we're gonna wash, clean, and we rinse, okay? And at this point, don't forget that you put your PPEs before going to the room, okay? You put your PPEs to do the sterilization. PPEs is gloves, gown. In dental, they have like a cover, a plastic cover that they put over their gown. And need to remove all the dirty the gloves, the gown, and the plastic who cover the gown before we can go. At at the entrance of the clean zone, we're going to have like a hand sanitizer to do hand hygiene. We cannot put another sink, but we're going to have like a hand sanitizer to do hand hygiene. And now at this point, you put new gloves, clean gloves to keep going to do your packing, your drying, and before doing packing, make sure that you inspect your instrument. You have to do it since you start watching them. You wash your instrument, you look. If it's not clean, you do the process again. Okay? I didn't put any pictures of what we found, but believe me, you need to pay attention to the inspection step. You have to inspect your instrument before packing, and the instrument needs to be dry, and before putting your in the pouches. This picture show you how the instrument should be during the whole process, all sterilization process. They need to be open. They need to stay open, okay? Because this is the only way that we can make sure that it's properly clean. Oops, sorry. Okay, so the next step is the packing. Like I told you, the instrument needs to be dry. They needs to be open. They needs to stay open inside the pouch before going to the autoclave, okay? For dental, we have autoclave and statin. When you put your instrument in the packing, you need to identify which one we're gonna use, if it's autoclave or statin. We need the date, and also we need the initials of the person who's packed the instrument. It's gonna be outside in the sealing part. Make sure that you seal the pouch completely, because if water goes inside, you're gonna have to redo your sterilization, okay? We cannot have water inside, it needs to be dry. So make sure that when you seal your pouch, it's properly sealed, okay? Again, like I told you, from pre-cleaning to the sterilization process, all your instrument needs to be open in the bag when you clean it, and when you inspect, it needs to be open, and out of the autoclave, they need to stay open too. So to be able to do that, we need to choose the right size of pouch, okay? If the instrument is too small, and the pouch is too small, it's not gonna stay open. So we need to choose the right size of the pouch. OB, you have inch instrument. How do you call that? The speculum, okay, needs to stay open. There is some you can even disassemble them, and after sterilization, we put them together. They need to stay open too. Okay, when you put your instrument in the autoclave, OB and dental, there is no difference. It needs to be, the paper side needs to be down, okay? Like in the picture, not the plastic one, the paper one needs to be down. And also, don't overload the unit. If you put too much instrument, it's not gonna be sterilized properly. So we don't want to like overload the autoclave or the statin. And your storage also, one of the findings was like we had too many instruments in the same drawer. So you need to, don't overload the drawers too. So make sure that you have your instrument, there is no link, there is no open in the bag, because when we put one on top of the other, there is more risk of damage of the packages, okay? And what we're gonna do and what we start doing already, okay? We're gonna do, we're gonna monitor compliance. How are we gonna do it? We're going to do direct or random observation. Some of you already saw me in the unit. Some of you already had their evaluation done. There is some of you I'm going to have to come back and redo it with you. But this is the best way to monitor compliance with you guys and make sure that you can do it. You have knowledge, so you need to be able to put it in practice properly. We're going to have to review the logs. The site supervisors, in radiology, the Rosie's going to have to redo the log. I'm going to do random walk to do during my walk, infection walk, during also common inspection. We're going to have to focus on those to make sure that everything is well done. Okay? I will come back for the competencies after. Any questions? I did good.
Now we have Margarita Vega. Is she here? She's going to talk about immunizations and a couple of issues that came up in the survey. All right, welcome.
Good morning, everyone. So like Dr. Amofa say, I'm going to talk today about some findings the Joint Commission have with us regarding immunizations and temperatures, vaccine temperatures. The first finding is that they found out that we are not constantly giving the vaccine information statement to the patients before they receive vaccinations. This we have to give to the parent or legal guardian, or if you immunizing an adult, they also need to receive it. So we're not doing it consistently across the border. We also have to approach the parents or legal guardian or adult if they have any questions about the immunization they're about to receive before we administer the medication. After administering the vaccine, we have to document the VIS form, the date, the VIS, the most recent one, and we also have to administer the date that we provided. I didn't do a screenshot because I did these slides from home and I didn't have access, but when you click when you give the vaccine, you have to click, and then at the bottom, it has the space to put the date of the vaccine information statement, and then at the end, it says given on, and then you put the date. Even though that the date is in the computer on the top, they still want it on that little box in the bottom. I also want to remind every one of you that give vaccination that it's very important that we are documenting the VFC eligibility when we give the vaccines. If the patients have any insurance like Marketplace, private insurance, Obamacare, Healthy Kids, they're not supposed to receive VFC vaccine. They're supposed to have the vaccine from our private stock, CHI stock, because they will not be deducted from your VFC inventory, okay? Now we move into the refrigerator temperatures. Although we're doing very good on this, there was a finding that they found out that there was excursion on the vaccines, on the refrigerator, particularly in the pharmacy and there was no documentation for them to excuse or to see any actions, even though we explained what it was done, but it was nothing in writing, so therefore it wasn't done according to them. So every time you have to monitor the temperature, remember to include the minimum and the maximum, especially on the VFC log that we have for temperature. Also, if you have any excursions, you have to take immediate action. As you all probably know already, one of the things to regulate the temperature is to add water bottles to the refrigerator. These water bottles are supposed to be through the edges of the vaccine and the bottom of the refrigerator, anything to try to keep the vaccine to be in the, on the correct temperature. Other things that we have to do is notify your supervisor if you have excursions and keep documentation of this event. You have to report it immediately to Florida Shot, either by email or by phone. And you also have to keep fill a vaccine incident form the VFC will like to have, and you keep those documentations on a file on your site. And when they come looking, and they did look, they wanted to show them proof that you have those documentations on the site. That was one of the findings. So therefore, this little presentation is to remind all of us that what we do is very important for CHI, for the patients, because if we do not keep this program, we lose funding for this VFC. We will affect a lot of the services that we give in the community. So please, 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 make sure we all doing proper documentation. And if you have any questions, please feel free to contact me. You know I'm at West Kendall. I'll be happy to assist you in any questions you have. Some of you usually reach me, like Kim from Tavernier. I'll be welcome, any questions you guys have. Any questions? All right, thank you for your great services.
Don't we have such talent? Isn't it amazing? Just amazing. Monica's beaming like there's no tomorrow. Jeez, relax. Okay. Thank you so much. Again, we'd like to remind you, we're moving 1,000 patients a day, and all of these kinds of things are happening behind the scenes. And it's important for us that you're all aware of them. And so as you ask the nursing staff for more things, remember, they're doing a lot of things behind the scenes that only they can do best. Now we have the privilege of another talent, Shante. She's going to talk about a lot of things. Lookalike, sound-alike medications, EpiPens, expired medications, multi-use cell solutions, emergency box, some basic codes, a lot. Welcome.
MLK Health Center. However, now I'll be at all your centers from time to time. If you see me come around, it's because I'm working my new title, which is the Nursing Clinical Coordinator. Okay? Well, Services Coordinator. All right? So we're going to be touching bases on a few things and a few items this morning. Some of them we have discussed from time to time in huddles if you work at MLK site, and some of them you had talked with your team leaders. Okay, so I don't know why I don't see my slides up, but Yes, I did. What? Jose? Okay. Well, anyway, I have such nice slides. I sent it in the email. Jose Carmona and Allison. You saw them? Okay, thank you. Before the time. Okay, so anyway, if you don't get the slides now today, you'll get them, I guess, in an email later after the presentation. I'm going to be talking about medication storage and handling. So a lot of the things that we're discussing, we just need to make sure that you all pay attention to detail. This is going to be repetitive. It's not going to be just a responsibility of nursing, it's a responsibility of providers, dental, environmental, and so forth. Because these are small little details that we take for granted day to day. As we're moving along and we're maximizing our medical assistance, we need you all to be more consistent and pay attention to detail as well. So the first, I was hoping that my slides come through, but y'all, okay. But the first thing I'm going to talk about is our look-alike and our sound-alike medication listings. We receive annual medication listings, and we all, if you look in your departments, we did receive the 2019 listing. And those medications are identified by a red dot. Some of you saw these listings in your areas? Look-alike, sound-alike. It's a posting, it has medication on it, then it has this red dot right on the middle. Okay, well, if you haven't, then you need to make sure you go back to your area, especially where medication is dispensed, and ensure that that listing is posted in your site or your department. Okay? These medications, of course, is what it is. These are medications that look alike and sound alike. They were just recently updated in May, so you want to make sure that you have the appropriate revision date of May 2019. Some of the examples of the medications that's on this list is TDAP, the DTAP. You see how that sounded alike? Well, we commonly get it mixed up. Hydroxyzine and hydralazine. Insulin products, Humulin, Humalog. So do you agree that those sound alike or no? Okay, and they can look alike when you spell them out. So we want to make sure that these medications are identified by the red dot and that they are separated in different bins and in shelves. So moving right along, we also have the high alert and hazardous medication list. Those medications have been changed and now are identified by the yellow dot. Some of the site managers have not been able to receive the yellow dots. However, I have some dots here. So if you're a site manager or you're one of my nursing members and you're going back to your site, please collect the yellow dots from me so you can get it at your site. Well, anyway, on the high alert and hazardous medication list, the dots should also be applied to the medication vial, box, or unit, just as, Pete, y'all got it? So, peep that, and I want y'all to see nice slides, okay? So, therefore, make sure you apply your dots on your medication as is indicated above. These medications are involved in a high percentage of medication errors and or sentinel events and carry a higher risk for abuse and errors and adverse reactions. So place these on these high alert and high risk list, place on medications that are on the high alert and high risk list from the organization's annual listing, such as epinephrine and Demerol. So let me just do a little quiz. For look-alike, sound-alike, what's the dot? Good. For high alert, what's the dot? All right, so we on board. So when I go back to these sites during command inspections and site visits, I'm going to see that these dots are located on these medications, right? That goes for dental, OB, family medicine, anybody who has medicine, all right? So moving right along, we have EpiPens. EpiPens, as you can see above, the contents for the EpiPens have two single-use pens to provide epinephrine for medical treatment and 1 trainer pen. I have Yuritsa, which passed around some trainer pens. We have been saying for almost 3 years, remove the trainer pens. Why? Because these trainer pens, I'm moving a little long, these trainer pens can cause an incident. In a case of an emergency, you may end up administering the trainer pen, which has no medication in it, when you need to administer the medication of the epi. Okay? So these EpiPens are used for treatment of severe allergic reactions such as a bee sting, insect bites, food, and drugs. So my school-based personnel, if you all have these EpiPens or EpiPen Juniors in your sites, make sure that the trainer pen has been removed. I have sent samples around. It actually indicates on their trainer. So remove the trainers. It's in red. All right, red. So, like I said, the purpose is to ensure medical personnel provide effective treatment. We do not want to accidentally use trainer pens at the time of a medical emergency. And for those at home, if you have it, please remove it from, you could teach your child or you could teach your loved one, but remove it, because in the case of incident, you want to increase your time frame for providing treatment. So moving right along. We have monthly medication checks, which we should be doing at all sites. Now that we have medical assistants involved in providing medications, I would like to involve you in doing the monthly checks as well. So refrigerator, freezer, and stock medications need to be checked monthly, routinely. Inspect meds that are not viable, damaged, or expired. What to do when inspecting? You want to make sure you bold the date, as you can see indicated on the slides. You want to make sure you circle expiration dates, because you can quickly just glance and say, okay, I know that's expired right here, and you keep moving. Label with open expired stickers. You see those little yellow stickers on the side of that Mylanta? We need to have that on the bottle, okay? So therefore, we'll have the open date and the expired date for multi-dose solutions. How many are doing this at their site? How many have seen a medication with a bolded date or a supply with a bolded date? So now, guess what? You get to take this back and go bold your dates. Get some black markers and write it out, right? No? Right? No? Right? Okay, that's what I want to hear. I want to hear actively involved, okay? So when we're doing a 3-month medication removal policy, we need to dispose of medication 3 months prior to expiration dates. This is a little tricky, but it's easy, it's simple. So I gave you an example on the slide above. If this is the month June, right? We need to make sure that we removed all medications that's July, August, and September. They should be removed out of circulation, so therefore we don't accidentally have that on the floor and we have expired meds. So these medications need to be removed from circulation and placed on a med disposal form with indicated reason and sent back to the pharmacy. So we got that? So if it's the month of July, this is tricky. I don't know what the answer is, so let me see if you're paying attention. If it's the month of July, which meds do we remove? Oh, that's so dead. Nobody knows what to do. Okay, which meds do we remove? All right, thank you. So I'm quite sure you got that. In the case that the medication is an emergency med, such as epinephrine, please label as such. This is our nurses. We need to make sure that we put on it July 30th, 2019. This med is already supposed to have been removed, however, it's an emergency med. Do we take the emergency med out of circulation? No. We want to keep that med there until we have received more new medication back from our pharmacy. So we would, as the labels indicate, mark it July 30th, 2019. We can put it ordered or on back order, okay? So you use either one. Do not remove the stock until updated medication is received. This step right here identifies that you have inspected and acknowledged the expiration date and currently in process of receiving a new supply or item. Okay? So we got it? Now this was a tricky one for me, and I must say, I was with my Joint Commission surveyor, and he ran across some sterile water. So do you think we remove the sterile water or we keep it once we open it? The answer's up there, guys. You're so sleepy. Okay, so multi-use sterile solutions we use once. Once it's open, we discard, okay? So I know the bottle is large. If you want, you can take a bath in the rest. I don't know. But just go ahead, you open it once, and discard it, all right? So you're gonna go into your different departments in your areas and you're gonna see sterile water. So if you see any open bottles, what are you gonna do right now? Throw it out. If you have a new one, you bold it, bold the expiration date, and leave and have that little open label on it, okay? But other than that, use once, discard. Now to talk about the medication emergency boxes. For those that may not know, but these boxes are stored in departments and facilities without crash carts. So don't feel like, oh, we don't have emergency equipment or medication to help those who is in need. So these are supplied at centers such as Everglades, South Dade, Naranja, because they don't have a crash cart. There must be documentation of monthly review of contents and oxygen. And you see the boxes? Come back. You see the boxes right there? There is a check sheet in which we have to check and monitor the meds monthly. These boxes also have breakaway locks. The breakaway locks need to be applied and replaced with a new lock when box is inspected. Now, during the Joint Commission survey, if it's an emergency, do you need to use scissors or a knife or a blade? You shouldn't have a knife, but some of us, you know how y'all roll with a knife. No, but should you have to cut the lock off with scissors? What about a blade? So you should be able to easily just twist it and it breaks, correct? So even if you're in the center and now you say, oh man, I think I might fall out tomorrow because I want the whole rest of the summer off, and you want to make sure the emergency box is good, go look at your emergency box, make sure that that person has a breakaway lock, not a lock like a tie twist on it so that you can access it, okay? So we have breakaway locks. So nurses, do we see the lock? We need to make sure we have those. Now, national patient safety goals from NPSG .03.04.01, they say make sure that before a procedure or in front of the patient, label medicine cups, syringes, and basins. Label specimen tubes and cups as well. Please do not do phlebotomy and you do not label the tubes in front of the patient or prior to being prior to coming in the room with the patient. If we're giving medication, that syringe must be labeled. What medication is in it? We have clear medications. If your whole tray falls and you have 4 vaccines, would you know which is which? Everything needs to be labeled to indicate what the solution or medication is. I gave some examples. As a matter of fact, I did that one with the syringe. We also have labeling of solutions. For our dental area, sometime in our environmental area, or depending upon where we're located in, we need to make sure that we label our solutions appropriately. So when removing solutions from its original housing unit or container, the secondary unit must be labeled. I gave you a quick example. No, we don't usually have the environmental products. However, they have a nice technique that I found. So they have the empty bottle, then they have an actual label, and then you put it on your product, the bottle that you're gonna use with that product in it. I gave some more examples because we also have single-use products which some people scoop out and they put the bottle on the side. However, that is a single-use medication, so you're not supposed to be scooping anything out to a secondary container. You utilize that one container and you discard. I also did an example of the multi-use product, which is the acetic acid, which you can pour into a sterile cup. Some of it, make sure you label that sterile cup as identified on the slide, and you go ahead and you discard that cup once it's done. So that is the end of my presentation. And do you all have any questions? Everybody saw the trainers? No? So I'm gonna go outside and test every nursing personnel on how to do a trainer if you didn't see the trainer. Everybody saw the trainers? Okay, that sounds a little bit better. All right.
Let me take a picture of Monica from here, actually, hold on. Jeez. That was phenomenal, just phenomenal. I really appreciate your ability to keep everybody so engaged. I looked around, took some pictures. Most of you were really paying attention. I think there were a handful of you who was looking on your phones. That's a shame. But I think I got you on camera, actually, and so we might post your picture up there on your phone, you know, while you're supposed to listen. Let's see, like who? JP? No, not JP. JP was paying attention. Well, mine is the easy part. I don't have slides like the rest of them do. Come on, I mean, mine is easy. Pain management. So we got cited on pain management in 4 areas. Number 1 was in a patient in whom we documented pain and we didn't assess the pain. Patient was like shoulder pain and there was no discussion of the pain. I'm going to talk about that. The second one was patient had pain, but it wasn't reassessed in subsequent visits. What's happening with the pain of this patient? The other one was that we didn't set goals with the patient's involvement for the long-term management of their pain. I'll talk about that for a second. And then in dental, a patient came in certainly for a dental procedure for a condition that would have caused pain, and there was no documentation of a screening or assessment of the pain. That was quite painful because we know you all know this stuff, but we'll remind you again on those for a few minutes. So the Joint Commission standards, which are really evidence-based, say the following. Number 1, we must screen patients for pain, right? And if the patient has pain, we need to assess the pain. Once we assess the pain, we need to decide on whether we're going to treat the patient or refer the patient for comprehensive pain management, right? But if we're going to treat the pain, we need to develop a treatment plan with the patient, and then we need to reassess the pain over time. And we need to involve the family, this last one, if necessary. So I'll just go over some of those very quickly. Screening, I think we do quite well, except for that patient in dental where we didn't do a pain scale that we normally do. So just please remember the dental staff, just do ask and document that on the pain scale. But when the patient states they have pain, like headache, right? We need to, as providers, assess the pain. Is the pain sharp? Is it dull? Does it radiate? How long has the patient had the pain? What makes it better? What makes it worse? Okay? All of those things are important in that patient's pain assessment. Now, it is not, the Joint Commission doesn't push this because they have nothing better to do. But actually, if this headache, okay, you think the headache is migraine, but you just documented headache, and that patient subsequently develops a tumor in the brain, you could have actually saved yourself if you documented an assessment that suggested you considered migraine at the time. But if you just left the headache hanging, you put yourself at risk. So it's not a good, just a good thing to do a good job with the patient, but it actually presents risk for you if you don't document completely. So when we find the patient has pain, let's pay attention to fully assessing the pain. Now, and then determine if we want to treat the pain or refer the patient for pain, comprehensive pain management. But if we're going to treat the pain, what is expected? The following things. Number one, certainly remember there's non-pharmacologic treatment and pharmacologic treatment, right? And all of those are important. But the big part is what the patient's goal is, or what the patient's goals are for the pain. If a patient has chronic pain, okay, chronic knee pain, maybe all the patient wants is to be able to walk comfortably. It may not be reasonable to say to decrease the pain to 0. Or maybe the patient pain is a scale of 8 over 10. All you want is to bring it down to less than 5. Well, what do you know? We got to ask the patient that. So I see you have knee pain, you had this for a long time, but what would you want to see? It's helpful to do that because if you don't, sometimes it gets very frustrating. Patient keeps coming back and they're not making progress, and they expect you to do miracles when sometimes you can't do much with it. So remembering to document the treatment plan with the patient involvement is important. How could that look like? So it's about setting goals for the patient. So I see you have knee pain, you have this for a long time. We know it's from arthritis, and we know that there's no cure for it at this time. But what do you expect to see? What would you want to see with your pain? And listen to what the patient says. I want to be able to walk again. I want to be, if I can have the pain come down to a tolerable level, I'm okay with that. And you want to document that. So the patient's goal is to bring the pain down to less than 4 over 10. That's a good goal. The patient's goal is to be able to walk with minimal pain. That's a goal. The patient's goal is to be able to wake up in the morning with minimal pain. That is the patient's goal. So we encourage you to do that. We know it's a little bit more time, certainly, but for the patients with chronic pain, it's important that you have a treatment plan, okay? It is our goal to work to develop some tools that will help with this. We always want to look at, can the patient help us with completing some things before we see them to facilitate our visit? And hopefully that will, with the support staff's help, minimize how much work the providers have to do in certain treatment plan goals. The last thing I want to mention is reassessing the pain. Please remember, patients have chronic pain. You want to ask them, document, how is your pain? Has it improved? Is it the same? Is it getting better? Right? And that's certainly doing the right thing for the patient. So in summary, we did have some findings that we didn't expect, but we expected to ask patients if they have pain, and we do that with our vital signs. Remember dental. We need to, patient has pain, assess the pain completely. With all the dimensions of pain we know as practitioners. And if we're going to treat the patient, please develop a treatment plan. Make sure your notes spell that out. And we're encouraging you to use a care plan tool and we're putting some cheat text to help you document possible treatment plan with the patient. And then reassess the pain, around the patient's pain over time, okay? All right, so at this time, any questions? Excellent. This time we're going to call on Dr. Riveron, who's going to talk about reviewing tasks in a timely fashion. We got cited on a few tasks that were outstanding. And there were a few medications that require monitoring that we did not monitor. We're very privileged to have him share that with us. So thank you.
Morning, guys. We got the PowerPoint presentation or no? Nice. Okay. So I'll just be briefly going over the timely review of tasks and monitoring of certain medications with appropriate lab levels. Yeah. So this is going to be very important. If this isn't done, Dr. Mofa is going to email me about it. So please try to review your task within 72 hours. So that's 3 days. And it's something that we should be discussing at each provider meeting. So, I mean, I can't stress that enough. But that's real simple. So just try to stay on top of it. Now, next slide. As far as the lab monitoring for certain medications, so I know we got dinged by Joint Commission for 2 specific medications, Clozaril and Depakote. These are medications that need to be reviewed within a certain time frame. If not, I mean, we will get dinged again. So I decided just to come up with a list of the more common medications that we do use. And I just created this comprehensive list of medications. So first one, acetaminophen. If a patient's taking Tylenol over 4,000 milligrams or 4 grams, we should be getting LFTs every 3 months. For the angiotensin receptor blockers used for hypertension, the serum potassium levels should be getting checked every 6 months because those levels can be altered by these medications. As far as the ACE inhibitors go, for blood pressure, serum potassium levels as well should be checked every 6 months. For amiodarone, which is going to be used for atrial and ventricular arrhythmias, we do want the LFTs and TSH levels to be checked every 6 months as well. For metformin, what you're going to see in a lot of the diabetes patients that we see at CHI, we want to be getting BUN and creatinine levels every 6 months. Cyclosporin you're not going to see too much of because the rheumatologists are usually the ones using it for rheumatoid arthritis, psoriasis, and atopic dermatitis. But you do want to get a trough level at least every 3 months. When I say trough level, it just means that you're going to want to take the level before the first dose during the day. Next slide. For digoxin, it's going to be used for CHF and AFib. You're going to be getting the BUN and creatinine trough and the trough digoxin level, every 3 months. So with that medication, it's very important to be checking to see how the kidneys are doing. As far as the diuretics, the most common ones being furosemide, hydrochlorothiazide, and spironolactone, we are going to want to see the sodium and potassium levels every 3 months because those could drop and it could lead to certain issues. Fibrates, which are used mainly for hypertriglyceridemia, hyperlipidemia, we do want to get a CBC and LFT level every 6 months, so not so often, but it is important. For PO glucocorticoids, so for any inflammatory condition, we are going to want to check the serum glucose levels because they can go up as well as the hemoglobin A1C level every 3 months. It's very important. As far as NSAIDs go, naproxen, ibuprofen, all that good stuff. CBC and serum creatinine every 6 months. Very important with the creatinine because the NSAIDs are known to, depending on the dosage, it could affect the kidneys. For phenobarb, which we probably won't see, we don't really have any neurologists on board, but every once in a while you will see a patient on either phenobarb or phenytoin. So it will be important to get a trough level of these two medications. For phenobarb, it's every 6 months. For phenytoin, it's every 3. All right, aspirin. So this is, it's a very high level. If you notice a patient's on more than 1,200 milligrams per day, you are going to want to get a trough level of salicylate every 6 months. For statins, you are going to want to check the liver with the LFTs at baseline, so before the prior dose, then at 3 months, and then every 6 months thereafter. For the thyroid medications, specifically Synthroid, that's the one you're going to be seeing most commonly. We are going to be wanting to check the TSH every 6 months. The TSH is going to be important anyways because the patient's it's usually going to be something from hypothyroidism or some form of hypothyroidism, so the TSH is very important. As far as warfarin goes, every month we want to be checking the INR. Now for the psychiatric medications, specifically for atypical antipsychotics, we do want to check the lipids and hemoglobin A1C every 6 months because these medications do predispose a patient to metabolic syndrome. So we do want to stay on top of that as well as the BMI. For Clozaril, this is very important. So CBC has to be checked with the differential every week for 6 months, then bi-weekly the following 6 months, and then monthly thereafter. For carbamazepine, we want a trough level every 6 months. That's pretty straightforward. For Depakote, it's going to be every 3 months. So that's one of the ones we got dinged for. So we have to make sure it's every 3 months. It's very important. For lithium, we want to do initial monitoring every 1 to 2 weeks until we hit the target serum level, which is anywhere from 0.8 to 1.2. Anything above 1.2, you can't start seeing anything from tremors to seizures to even renal failure. So with lithium, very important. So every 1 to 2 weeks until we hit that target range, then every 2 to 3 months, the following 6 months, and then we could wait every 6 to 12 months thereafter. SSRIs, very common. So SSRIs predispose patients to a condition known as SIADH, which basically just means water is being reabsorbed. So what happens is sodium levels can drop. Patients can end up in an ER or hospital setting. So we want to get a serum sodium at baseline, then the serum sodium anytime the dose is increased, and then after that, just once a year. And then for the TCAs, it would be important to get a trough level. So when I say trough, like I said, it's going to be before that first dose in the morning. And those medications, just once a year is sufficient. And that's it. Thank you, guys.
That was amazing. Thank you so much. That really exceeded my expectations. You knocked, excellent. Thank you so much. And we will certainly monitor these things through peer review. And I'm thinking that working with Allison and Shay, we can also pull certain data to look at patients on a medication, have they had blood levels, okay? Yes. You want to get up and speak to the group? Here.
51.81. Therapeutic monitoring of any drug level is Z51.81. And if somebody's on a statin or aspirin therapy or an antithrombotic, basically it's Z79 point whatever it is. There's several codes for each medication. So you want to be sure to list the diagnosis of the patient as well as the long-term use in order for Medicare or any other insurance to properly pay for it. So for the lab, and for the nursing staff that's doing requisitions to the lab, please make sure that those codes are on any type of drug monitoring or liver profiles, liver function tests, things like that for long-term use of statins.
Excellent, thank you so much. And I'm guessing she's going to email that to us, so I know some of us won't, so please email that to us, okay? All right, last we have Patricia coming up again on competencies.
Okay, so we went through nursing to dental to OB, and everything is about competency. We used to do competency here in CHI, but we are in the process to review the way that we're doing competencies. If I take nursing competencies, for instance, we used to go there for 5 hours, I think, and you sit and you go through the wave test. Like we talk about the wave test, like the A1C, the glucometer, and everything. So this is not competency. Competency is hands-on. So now we're going to try to make it better, and why we're going to do it, it's to implement and ensure a culture of safety, not only for you, but also especially for the patients. So what we're planning to do, it's like job-specific competencies. We have the initial competencies. We would like every new employee to come here in CHI to have their competency before going to the floor, before going to the units to do patients care, because we want quality and safety care for our patients. Okay, when you're gonna introduce new products, like the Empower that we're going to use soon, starting next week, or the new ultrasonic machine that we're going to put in dental. We need competency because we don't know how those things work. So we're going to read, which is the training, and then we do the competency. Letitia and myself, we go with each of you through the use of the IFU, like instruction for use, for the Empower before you can start using it, okay? When we're receiving the ultrasonic machine, we will do the same with you. So everybody will be on point, and there is no, I don't know, they never told me, I don't know how to do that. We need to be on the same page, everybody, okay? Annual competences. We do annual competences, and like I told you, we're going to review the way that we do it. We have the training. We need to make the difference between training and competences. And Dr. Amofa told me a lot about it, okay? And one of the findings of Joint Commission, it's like we didn't have any, we have training, but we didn't have any competences in our employee chart, employee file in HR, okay? The wave test competences, it will be done with Armando Hall and myself. Wave test, we know everybody knows what wave test is, so we're gonna go over it and you train you, and we do the competencies. It's 2 steps, okay? Like I told you, instrument-specific competencies with new instruments that we see, we will have a competency also. When you look at this, when we look at these slides, okay, I know everybody here has knowledge because I test you. Everybody knows what they have to do, okay? The only thing missing, it's like you have skills, you have knowledge, so you need to combine them together to be able to give safe safe care and quality care to the patients. And this is where the competency goes, okay? And the core concept of competences, we have 3 cores. We have the values and attitude, we have the skills and behavior. We need to think that, okay, if I go to the dentist today, how do I want them to treat me? Okay, my philosophy is, okay, treat everybody the way that you would like to be treated. I don't want to go to the dentist and see a dentist put a dirty instrument in my mouth. Okay, so think about it. Okay, you want to have quality and safe care. It's the same thing for our patients. Okay, regardless their race, their language, their socio-economical level, everybody needs to be treated with respect and have safe and quality care. Okay? Any questions? That's conclude my report.
What can I say? Can all the speakers please come up for a second? Can you come up, Shante, Margarita, please? You'll have the chance to ask them questions, but I'm going to ask them, if you don't ask them questions, to quiz you. So each one of you think of 1 question to ask your group, okay? Alison, do you mind? Can we please give these people a round of applause? That was amazing. Thank you, Alison, for putting together this amazing, very well-structured agenda. That was very well done. You know, it takes thinking through these things very carefully, and I truly appreciate that. I thought I had to do that, and I didn't do anything with it. She just showed it to me, and I was just blown away. So I really appreciate that. For you guys to spend so much time and energy putting together these amazing slides, that is class. I am truly proud, and I'm sure Monica and JP will say the same thing. Really, thank you. This stuff takes a lot of time and effort beyond your daily responsibilities, and we really appreciate that, okay? Thank you. So do we have any questions for any one of them? Otherwise, they're going to ask you questions. Excellent.
Can you go to the mics? I think they're on.
You asking for the slides? Yes, all the slides are going to be emailed to you, okay? Excellent. Another question? Is there a question? Oh, I'm sorry. Okay. If there's no question,
I need my trainer pins back. Ooh, who's on the trainer? Just pass it back to the side.
check JP's pocket. I'm sure it's in there somewhere. There's a question? Okay. If you can come to the mic, that'd be great. Otherwise, I'll repeat the question for you.
Hi, I just want to know where I can get the red dots and the yellow dots.
At your local Office Depot. No. We can actually order it from the logistics department, the purchasing department. Okay? So, okay, so Vivios will be in charge of making sure that you all get your dots, okay? I do have the yellow dots here with me, so, because we just did a transition, so if you need the yellow dots, please stop by and get the yellow dots from me right now. At least we can start. So if you don't get those red dots from Vivios by the time school start, please, at least 2 weeks prior, alert us.
I have one question for all of you. Who should not receive VFC vaccine? Can anybody answer that? One person at a time.
Raise your hand, be great. Okay.
Anybody else? So basically, children who are eligible for vaccine for children include Medicaid recipients, the uninsured, as well as those that are underinsured, which with the Affordable Care Act, all insurance should cover immunizations for children. VFC is eligible for children from 0 through the 18th birthday. At 19 and 20 years old, Medicaid still covers vaccinations, immunizations. However, we have to use private stock, and Medicaid is billed for the immunization. So I just want you all to be aware and to be in compliance with VFC that, you know, commercial insurance, those that are on the Affordable Care Act, those that are on Healthy Kids, all are not eligible for VFC. And how do you know they're on Healthy Kids? Well, besides looking at their insurance, normally they have a $5 copay. Okay, so that's what I wanted to say.
When do we return medication back to the pharmacy? What's our policy? How many months? Okay, good job. So I know y'all was paying attention. If we have 3 pens in the epi box, which one do we return? All right, I tried to be hard.
Okay. This is for OB and dental. At what point you have to change our PPEs when we're doing sterilization? I cannot hear you. Huh? Okay, but what is the step missing there? You're missing a step. So what do you do when you're done with your PPEs, removing the dirty PPEs?
What?
When you're done going from the dirty to clean, what do you have to do when you're done with your PPEs? Remove
Sanitize your hands.
Okay, thank you. Okay. The question was, at what point you remove your PPEs? You had it right. It's like before going to the cleaning, when you're done with your instrument, before going to the clean area. But there's a step. I ask you, what do you do when you finish removing your PPEs? You need to do hand hygiene. Okay?
And for me, when do you give the vaccine information statements? Before you give any immunization. Actually, the practice will be best if you give it while you go to prepare the vaccine so they have a chance to read it. And then when you come back, you ask if they have any questions and you'll be able to answer before you administer the medication. Also, what do you do if you have excursions on your refrigerator temperatures? You had to report it, yes. And you had to keep documentation. That's the most important thing. You keep documentation and you report it to your immediate supervisor and therefore to the proper channels after that.
So how often are we supposed to be reviewing our tasks? Within how many hours? Okay. How often should we be checking valproic acid levels? Who said it? 3 months. Valproic acid levels? What about lithium? It's a tough one. Okay, so it's every 1 to 2 weeks until you hit your target range, then every 2 to 3 months for 6 months, then every 6 to 12 months afterwards. I don't want to.
And remember, we have to close our notes and review our labs within 72 hours and make sure that all tasks are closed, okay? Price is right, come on down.
No, just an information for the group. What is considered normal temperature for the fridge when you in the vaccine? What's the maximum you can go and what's the lowest?
From 35 to 45 degrees will be the best ideal temperatures for the refrigerator. And for the freezer with the vaccine, they could go up to minus 30 degrees and no higher than 5? 0 to 5. 5 below. You could go to 30 below, and that will be acceptable.
We have to remember, we're documenting
My,
Fahrenheit.
I'm sorry? Fahrenheit. Yes, Fahrenheit degree. Any other questions?
Go ahead.
Hello, can you hear me? It's for Shantae. You gave, yeah, you.
Yeah, I know who I am. Go. Roll.
Congratulations. Congratulations on that.
Thank you.
Hey, so I'm going back to, I'm not in nursing, but I'm just curious. The example you gave of using the sterile water, it's a multi-use, but you can only use it once.
Right.
Now, what happens in a situation if you're in pediatrics and you're treating a family of 3 and they all have the same issue where they can use the same water? Do you get 3 different waters?
No, I can actually use that bottle and pour it into different cups. So I can actually use that one bottle. I opened it one time and I actually put it into 3 different secondary containers. And I can use that one fluid that one time. I cannot recap it and put it back on my shelf for later use. Did that help? Help answer your question?
So when you say, I want to be...
Yeah, if they're in the same room, of course.
Just ask, 'cause like I said, again, I'm not a nurse.
No, but it's okay because you all are our patients, and then at the same time, if you see that one of us are not doing the appropriate measure, you can go ahead and step up and say, hey, this is what I learned, and this is what I was taught, and you'll be aware of. And if it's not just us, if you go anywhere else, you'll be aware.
Okay, so with that same, if you use it, not necessarily, somebody, say for instance, back to school. Everybody's coming in for immunizations or whatever. And same example where you know you're going to be using one of those multi-use things, and is the rule is throw it away after use, or as long as you get rid of it by the end of the day? Because you may have somebody that come in morning, midday, and towards the end of the shift that can use the same thing.
The best practice is to throw away right then from that use, because it's a sterile irrigation solution. So that means I just can't go and move to another patient.
But that's just reference to water. I mean, there's other things that's multi-use that may not.
No, but I'm identifying the sterile. We do have multi-use solutions such as the sodium chloride solution. We need to go by the manufacturer's date. But the sterile water, because it's sterile, which is one-time use, and then we discard. Got me? Well, okay, yeah, single use versus multi-use. I'm talking about the single use. In the single use of the one I was talking about was the sterile solution.
I thought you referenced multi-use.
No, that was the sterile solution. I was identifying sterile solution, which we found on a Joint Commission survey. Sterile solution. However, it is a single-use item for us now. Okay.
So it's CHA policy to use it once, not.
Yeah, it's hard to hear you.
Oh, I'm sorry.
The sterile solution was a big bottle. They only used a little bit of it. That should have been discarded after use, okay?
So just as a statement of fact, okay? Statement of fact. Now, I hope you're not talking about vaccines. Different story.
I'm just going off the example she presented.
Yeah, what she presented, that sterile solution, exactly as she says, we're going to use it that time and that's it. Yes, that's CHI's policy, if that was a question, okay? Any further questions, as you reach out to her, but hopefully the staff is going to use them, make sure that guidance is very clear. Okay, I think our time is up. We have 6 more minutes. Let's stay behind, but I want to say thank you to you guys again. That was excellent. Let's give them another round of applause. Don't leave yet, please don't leave yet. Monica, JP, you have any closing comments? Allison, you want to go first? So you guys, thank you so much. Closing comments?
I just want to thank you all for attending, and I'd like to thank our presenters for presenting. I think they did a fantastic job. And if you have any questions or any concerns, please feel free to reach out to any one of us. We'll be happy to answer your questions. We have the experts here. And I'd like to thank you for attending, and hopefully this will be the first of many trainings to come.
Thank you, Allison. I want to echo that, because when we first sat in Dr. Zamofa's office going through the agenda, I thought, oh, you know, how can we keep their attention? But this is really excellent. You did a good job putting the agenda together, and I want to acknowledge to both of you for that. And then I want to personally acknowledge my team leads here. Dr. Mofa was pushing me to talk, and my thing is no. I want to sit back and empower my team. And I'm really proud of you guys, and I think you did an excellent job in engaging the team. And I really think we all benefited from this, and we really should find a way to do it more often. So again, thank you guys.
And just remember, all of these issues affect every single one of us in every single one of our departments. So it's not isolated to dental or OB or family medicine. Really, the more we know, the better off we're empowered to correct things that are wrong.
I just want to echo the comments of the senior leaders. Phenomenal job from those that presented. Also want to remind everybody that, you know, we just went through our Joint Commission 3-year accreditation, but my philosophy is we should be Joint Commission ready every day. So let's not wait until 3 years to make continuous improvements in our system. If you see something, say something. If you need clarification, ask those questions. Let's not wait until we have surveyors on campus or we have any other funding sources on campus to make those corrections. So wonderful job. We'll do it again in 3 years. But let's not wait until then to make those day-to-day changes that need to be made from an operational and clinical perspective.
Thank you again. Let's give them another round of applause. Thank you. And I'm required to let everybody know, please drive safe back to work. Please look around you. Any bottles of water, tissue, paper, even if you didn't leave it there, please. This church is gracious enough to have us use the facility. Let's please make sure we remove everything that should not belong in the church, okay? Thank you all and have a wonderful day.